this conference. I'm going to talk on some interesting topic. This is the new topic picking up nowadays. This is a fetal brain development in GDM. There is a lot more to learn from this topic. Thank you, Rutil, for giving me this topic. I also learned a lot. So before going to the discuss about what is the some basic embryology of our fetal brain development. We all know that neural tube is the most important part. The neural tube starts by end of second week or 18th day, the 19th day neural tube formation starts by the end of third week. By 21st day, within 4 to 5 days, the whole neural tube formation has been finished. So if any problem in this, we'll have all the meningocele, encephaly, all the classical complications of diabetic mother will have within the first 3 weeks, it all develops. And after this, once after 4 weeks, a neural tube formed, it able to form a primary brain vesicles like forebrain, which is responsible formation of cerebral hemispheres, basal ganglia, thalamus, mesencephalon, which is responsible for midbrain, and the hindbrain, which is responsible for the pons, cerebellum, and medulla oblongata develops. All these things happen within a period of 8 weeks. By the end of 20th week, the whole brain is ready for further maturation or further development. So by the 4th week, the neural tube completely devolved. By the week of 20th, the cerebellum, everything is formed. And the end of second week, the demyelination started. By the end of third week, the synapses sets in. So the brain is ready to have a full actions once it born. So if you see the metrics here, the volume increases almost 250 times from 4th week to birth, full term. And almost from the 28th week, the full form of sulci, gyri, what we call it as cerebellum, everything has been ready. And there is 3% increase in total surface area happened from 24 weeks to 38 weeks. And let's see about something what happened in GDM mothers. If there is after 28 weeks, we have seen that the connection between the two cerebrum started with the thalamus, corpus callosum, the connectivity starts. So the two brains started talking each other by creating more synapses. This is the most important organ in our brain, particularly corpus callosum, which is shown in the green color here. It starts by 12th week. By the end of 20th week, it is fully developed. What will happen that it is the largest white matter structure in the brain. It is happen to be essential for connecting interhemisphere communications. This is the most important for memory, sensory, motor communication between the two cerebrum. So it has almost 200 to 300 million axons. So any problem in this corpus callosum will have autism, intellectual disability, or seizures. And hippocampus is another one of the major part in our brain, which is because it starts by 7th week. It is a main center for learning memories, learning and spatial navigation. It have a high metabolic demand. Whenever there is metabolic derangement, particularly like hyperglycemia occurs, it directly attacks the hippocampus. So new learning, particularly the ones the GDM mother having hyperglycemia or hypoglycemia, the learning capability will come down to the fetus. And the ventricle system, it also evolves by over a period of 12 weeks to 24 weeks. This is most important to assess by through ultrasound. With the ventricle size and enlargement, you can able to assess overall brain development, whether it is happening normally or not. So ventricle assessment is most important. And there is something called cavum septum pellucidum. This cavum septum pellucidum is here. It is blinking like a red color. It is a fluid-filled space between the two lamina of septum pellucidum. It is developing by 16th week of gestation. It is an important neurosonographic marker for normal brain development. This is also most important part here. How this glucose affects. We all know that glucose is the principal source of energy for our fetal brain, and the glucose intake into the brain, particularly through by blood-brain barrier, will be GLUT1 and GLUT3 receptors. We all know that these two receptors are insulin-independent receptors. Whenever hyperglycemia occurs, directly all the glucose goes into the brain. It will affect. We all know that blood glucose is mandatory for ATP formation, so that synapses will have myelination will occur, and the reduction potential will be improved better than, so that antioxidant property will come down with the available glucose. Whenever high glucose is there, we see with any diabetic patients, it induces oxidative stress. It directly affects the neurons. It also affects the mitochondria of the neurons, and it also alter the gene expressions. It down regulates so many neurons here. It also have a epigenetic modifications. We all know that one GDM is sufficient enough to translate all the defects in the successive generations. As our professor used to say that the transgenetic transformation will happen in GDM. So this epigenetic changes represent the mechanism which normal metabolic environment during pregnancy have abnormal metabolic environment in the pregnancy having lasting potential transgenerational defects of the offspring, particularly if the baby is a female, the next generation going to be affected. So role of insulin, we all know that so many our previous speakers also pointed out that whenever there is hyperglycemia in the mother, it goes to the hyperglycemia into the fetus, there will be hyperinsulinemia. But the beauty here is whenever the hyperinsulinemia happens, it will down-regulate the insulin receptors in the brain. Whenever insulin receptors are down-regulated, we all know that IGF-1 is important for growth factor. So whenever it is down-regulated, the synaptic function and the memory consolidation, all these things become affected. So not only directly by hyperglycemia, also by hyperinsulinemia, by down-regulating the insulin receptor, it also have an effect on the fetal brain development. And microglia information, we all know that microglia is the most important for the brain development. So whenever there is an inflammation, this inflammation will activate TNF alpha and TNF1 beta. This chronic inflammation persists even after the birth also. So this inflammation have a lifelong effect and it impairs the synapses formation. It also apparent connectivity also occurs with this microglia information. And gut microflora of the mother, we all know that whenever the short chain fatty acids is good, we have a good microflora. The altered microflora during GDM will have a bad short chain fatty acids production. It also impact on the inflammation of the baby, thereby the brain development. The lipid metabolism, particularly in the GDM, if the mother have a hyperlipidemia, it also affects through the deoxyxonic acid transfers to the baby's brain. So what is the evidence we do have? How can we pick it up whether this baby have a problem during pregnancy, particularly in the brain, all these things? These are the 4 parameters usually the radiologists look into it. The corpus cavernous septum pellucidum, the CSP. CSP will tell us the midbrain structural integrity, and the corpus callosum will tell us the connectivity, any disarrangement in the connectivity, and the lateral ventricle will tell us what about the fluid dynamics and the overall maturation status, and transcerebral diameter will tell us the growth of the brain of the baby and the future development. The enlarged cavernous septum pellucidum in GDM, it is quite common in GDM. Almost 23% of mothers will have enlarged cavernous CVP or enlarged cavernous septum pellucidum. This is a cavernous septum pellucidum here. So one of the most consistent neurogenic markers. Once we bring down the sugar, definitely the gap will going down, the enlargement will going down. It not only help us to assess whether the fetal brain has been affected or not, with the treatment whether it is improving or this also really help us. And enlarged lateral ventricles in GDM, this is mild enlarged, here is moderately enlarged, here is a severe enlarged. It tells us that altered brain fluid dynamics and delayed neurological maturation in the fetus. It also helps us to know that, track the response to glycemic control for second trimester, end of third trimester. We can able to assess whether this glycemic control improves the brain development. Corpus callosum have a significant changes. Thin corpus callosum, there is a small or big. There are so many changes happening in the baby's brain. So thinner or delayed corpus callosum development is also common in GDM exposed fetuses. It help us to brain primary. It is we all know that corpus callosum is a interhemispheric communication pathway. So whenever there is delayed or thin formation is there, it happens due to delayed myelination. It happen to be impact on the executive function of the baby. So the baby's executive function will be affected in later part of the life. So potential neuroimaging will be sometimes fetal MRI will be useful to assess about cortical development and gyriform patterns and ventricular system anatomy and white matter tract formation, posterior fossa structures. But usually we do neurosonography with the help of cavernous septum pellucidum with the help of lateral ventricular dimensions, corpus callosum development, and cerebral growth trajectories and cerebral blood flow patterns through Doppler. We can able to assess that how about the fetal brain has been developed well or not. So the neurodevelopment outcomes linked to the GDM exposure obviously will alter this neural brain development, and it will have an impact on the cognitive pathways, and the ADHD risk is quite high. The autism spectrum disorder is also quite high with these babies. But I don't know why this is the reason behind this. Male offspring particularly vulnerable to neurodevelopmental complications following GDM exposure. So obesity also have an impact on the brain development. Particularly, it alters the appetite regulations and reward sensitivity. This will help us. This is a way the baby once become a adult or childhood adolescent, they become obese. We all know that GDM mothers, GDM babies will have obesity in later part of life. This is a way that it alters the hypothalamus level, so that the appetite satiety center has been rearranged. The baby become obese, particularly in the adulthood or adolescent period. And apart from the hypoglycemia also have an impact on the baby's brain development. We all know that glucose is a primary source of energy. Whenever there is a hypoglycemia, it impaired ATP production and the energy of the cell also going down, so that the risk of neuronal injury and developmental delay. So that we all know that whenever the mother had a frequent hypoglycemia, particularly during pregnancy, there is some cognitive delay, and the developmental delay will happen to the baby. And hypoglycemia will have a cognitive impairment, attention deficit, and motor delays in the babies. And ketones, we all know that ketones also an alternative source of energy for the brain, but there should be some threshold for this. Whenever the threshold goes beyond, whenever the toxic levels reached, it disturbs the normal neuronal development and myelination processes. So high ketones also have an impact on the baby's brain. What about drugs? Whether insulin or oral hypoglycemic agents will have any impact on the drugs? As of now, there is only one study is available. There is no significant difference in the neurodevelopmental outcomes whether you use insulin or metformin during pregnancy. To conclude, definitely GDM have a significant impact on the brain development of the fetus, and we have some critical moderators. Hypo and ketones has to be monitored apart from hyperglycemia while dealing with GDM mothers, and there is some imaging potential is there. Particularly neurosonography will help us how the brain is developing, and it is easily preventable. If you pick it up very early by producing better glycemic control, definitely these changes can be reversible at the earliest. So keep in mind that always assess sonography for fetal brain assessment. So this fetal brain assessment, if it is found abnormal, this is a lifelong process. Even after 6 to 12 months, we have to repeat the scanning again, and we have to continue monitoring. And whenever there is autism, spine, or ADHD, early intervention has to be needed for this baby to have a good healthy life. Thank you for your patience.